Thanks, Jeff. So let's get started here, see if this thing's going to work. Okay, so the previous slide is identifying patients at risk, making the diagnosis. It might also, for some, be trying to find excuses for not performing intraoperative imaging and clearing the CBD, and for others, it might be how much time and money do you want to spend before doing the same thing. So that's my backyard. Those are some of my pets. I have no conflicts or disclosures. However, you may notice that there is some bias against not being able to do what we're supposed to do in the operating room when we're treating biliary tract disease. So we're just like Dorothy and Toto and the Wizard of Oz. We're there trying to find our way down the yellow brick road. And you can see that what we want to do is change the image on the right to getting those stones out on the left. This is an algorithm that we follow. I'm going to be talking about the top part of this algorithm. This was published in Cameron's book a few years ago. So I'm going to be talking about the pre-op evaluation with ultrasound, MRCP, CT, and ERCP, and LFTs. So as we know from history, and part of this is going to relate to history as much as anything else, because the pre-op evaluation can otherwise be somewhat boring. We know that open chole started in the 1800s. The first open cholangiography, 1931 in Argentina, being followed by the first laparoscopic cholangiography, 1942. So what have we been doing for over 50 years when we so-called rediscovered this? The first laparoscopic cholangiography in Europe was in 1954. So we know after 1989, when lap choles first started, that there was a lot less intraoperative cholangiography being performed and a lot more ERCs. Well, from 1994 to 2013, I get the impression that people are being taught, well, avoid the common bile duct at all costs and find some other excuse for not clearing the duct. This is a picture of Maritzi in 1931, for those of you who may not have seen a picture of Pablo Maritzi. This is his article, Laparoscopic Cholangiography, in 1952. In Europe, this is Professor Andre Colomet. I met him in 92 at the first Swiss Congress of Minimally Invasive Surgery. Colomet actually published this article, Laparoscopic Cholangiography, in 1954. And you can see the sticks here, you can see the common duct stone. As I was told by Andre, his professors told him to stop screwing around and get back to doing something more useful. So he stopped his work there. As we all know, MUA did perform the first laparoscopic cholecystectomy in 85 through what he called the galloscope. A lot different than how we do it now, but when you think about the single incision stuff, maybe MUA was onto something back in those days. So in terms of how surgeons approach this, before 1990, we were expected to clear the duct 90% of the time. For the younger surgeons, that was the history. When lap choles started, a lot less than 90% clearance was expected. And again, nowadays, it seems like most surgeons are hardly willing to get to the common duct. Now, this is a very telling slide that was given to me by Dr. Magnuson from Johns Hopkins. This shows the incidence of the number of cases, the mode, if you will, for general surgery residents graduating. The average lap chole and open common duct total per chief graduating to sit for their boards is less than 1. So we have a serious problem here. So as we know, the classical predictors of CBD stones, history of biliary pancreatitis or jaundice, increased LFTs or amylase, and on ultrasound either CB stones or enlarged CBD diameter. Yang published a paper in 2008 where they looked at over 1,000 patients and they looked at the biochemical markers. And they made a nice comment early on that in the era of open cholecystectomy, when IOC was routine, surgeons didn't really worry about the pre-op workup all that much because they knew when they did their cholangiogram, if they found stones, they were going to get them out 90% of the time. So they didn't worry too much about what we have to worry about now. This is some of the data from that paper, and they looked at 5 of the parameters here, and they were looking for the negative predictive value of these, and you can see it's actually quite high. Sonography, as far as sensitivity, was quite low, but the predictive value was reasonable. So they were looking for reasons that you could avoid doing an ERCP. And the most interesting factor was that the GGTP had the highest odds ratio for determining the negative predictive value of common duct stones. So in their conclusion, they indicated that biochemical tests were the ideal non-invasive predictors for the absence of common duct stones. They also admitted clearing the common duct laparoscopically is a technically demanding feat, and most surgeons don't have the skills to do that. In their final thing, they say the preoperative ultrasound and simple liver function tests are all that's required to make a preoperative diagnosis of the absence of stones early on. Now, you can take some of that data and perform this calculation by Huger and all, where they took the patient's age and then added all these various things, and if you have time to do all that in a small Cray computer, you come up with a probability of somebody that may or may not have choledocholithiasis. I guess I'm just not interested in doing all that. Now, Bill Traverso and Kenny Koo back in 1996 looked at their very well-controlled group of patients. They had a very tight HPB group in Washington State, and they looked at the history, biochem, and sonography, and what they found was the best predictor was history at 45%, biochemical abnormalities at 30%, and ultrasound at 28%, and their conclusion is that there were no predictive tests that can sufficiently increase your probability estimate of the presence or absence of stones to allow for selective IOC decisions. So what does that lead us with? That leads us to ERCP, and we can see that's been around a long time, since the late 60s, but it is somewhat operator dependent and requires ionizing radiation, and there's a non-zero morbidity and mortality to it. So Aaron Fink in 1993 wrote an editorial for SAGES when we were trying to figure out should we be doing ERCP on all these people or not, and Aaron's conclusions are that the indications for it are acute severe pancreatitis, cholangitis, or possibly a concern regarding gallstones in the common duct. So in his final statement, he said that routine pre-op ERCP is contraindicated and that role may decrease as the techniques for CBD exploration improve. So what are we left with? Well, we get to MRCPs, which the basic work was done in the 50s through the 70s. The first MRCP was done in 1986, and you can see that it's less operator dependent. There's no ionizing radiation. There are some problems with metal clips and things in patients. And this is an example of a fully loaded truck, pallet truck, that had metal on it when somebody accidentally energized the magnet when they were putting the thing together. So we have to worry about some of the problems with ERCP as well. So how about the cost of determining all these things? Well, Polos has two articles that I'm going to reference here. In 2006, they looked at the propensity scores for patients, which, and the propensity score, they said was the probability the patient might receive a common duct exploration based on the comorbidities and demographics. And without going through all the details of their paper, they had three striking findings. There was less patient resource used with common duct exploration. Only 7% of patients with common duct stones underwent common duct exploration, and the low use of CBDE was related to these factors here: the increased time, the perceived higher costs, and the low IOC use. So their conclusion was that CBD incurs less total health care costs, total hospital costs, reduces length of stay, and has estimated costs comparable to ERCP. That was their 2006 article. Now in 2007, they produced another article that, and if Dr. Pelos is here, I'll be interested in his comments later. This article has to do with optimizing the resource use from an institutional perspective. And for a number of you, this should scare the bejeez out of you. So they looked at the institutional perspective for laparoscopic common duct exploration versus ERCP. They found two important findings. First, they found that ERCP, as opposed to laparoscopic common duct exploration, in their opinion, was the optimal choice for incidentally discovered common duct stones. Now, they base this on a number of theoretical things, not on actual data. The 2006 paper was based on actual data. This was a theoretical calculation based on a number of theoretical assumptions. They also talked about the opportunity cost of doing a common duct exploration laparoscopically, that is, the extra time you take in the operating room that somebody could be doing another case. Again, they say these data can be used by individual institutions. So imagine having your OR nurse director come and tell you you're not doing a common duct on this exploration on this patient because we're going to lose another case. There are some problems with that. Again, having institutions tell us that we can't do a certain operation is in my opinion, quite scary. In the invited critique from Dr. Schulich, he indicated that there's a bit discordance between these two papers. One paper, based on actual data, said that laparoscopic common duct exploration is better. The one based on theory said ERCP was better from the institutional perspective. Some significant problems there. Bill Traverso, in another paper that he wrote, showed this center line with the yellow bar is lap chole and laparoscopic common duct exploration to clear the stones from the duct. These three bars on the other side here are basically twice as much, choosing ERCP or open common duct exploration. So this still, way back then, even in 1996, turned out to be the best way to do this. From a surgeon reimbursement perspective, we looked at our area around the Kansas City area from these various companies. If you look at Medicare, the yellow bar is lap chole, how much they reimburse. The orange bar is how much more they pay for laparoscopic common duct exploration. The green bars are those for IOC. So you can see they don't give much weight to IOC. And you can see that these other companies here don't really want to pay you a whole lot more for spending all that grief in the OR trying to clear the common duct. If you look at the imaging charges in the preoperative workup, which is what I was supposed to talk about, you can see that ultrasound doesn't cost so much. Interestingly, at least in our region, MRCP costs less than CT of the abdomen, and it's actually much more sensitive. Endoscopic ultrasound obviously costs more. So as I'm getting to the end of this, I think we need to go back to the NIH conference in 2002. I was fortunate to participate in that. In 2002, they had a conference, common duct exploration versus ERCP. The conclusions from the panel were that the common duct and post-op ERCP are safe and reliable in clearing the common duct stones. They also indicated that there is a need to enhance and evaluate the training for laparoscopic common duct exploration. So I think we've probably not done what the NIH recommended back in 2002, since the average resident graduating nowadays has at most one open or laparoscopic common duct exploration under their belt. Thank you.